So welcome back to the FKB Physio podcast. My name's Frances Brown and I am the host of the podcast. I'm a physiotherapist working in Brisbane, Australia, and I haven't done a podcast in ages. And part of the reason was because I was setting up this awesome new gym space that I now work in. So I work between Fortitude Valley and Bowen Hills. So I'm in this awesome space in Bowen Hills that is, well, my own in many ways, which is really cool. It is a full gym, and I hope that this is the direction that physio spaces look in the future. Your sort of traditional physiotherapy space is like a bed in a room and that's it, which is fine, but I can't imagine practicing that in that way anymore when so much of what I do is getting people exercising and moving, and especially if you're working with people who train in a gym or train for sport, you often need to see them doing larger movements than what they could do in just like a room with a bed. So I'm lucky that I have this whole space now, and yes, it's been a lot, but it's done, and now I can record some podcasts again. So today I want to talk about tendinopathy. I've done a blog about this as well, so if you're someone who prefers reading than listening, you can just go to my website and check it out there. The reason I'm doing something so specific is that I get a lot of patients coming through the door with tendon problems, and sometimes I feel like it would be easier to just refer them to a resource to learn a little bit more about it. So tendinopathy is just like an all-encompassing term. It just means a pathology of your tendon. So it basically just means your tendon isn't healthy. They stopped using the word tendinitis because they found that often inflammation, which is what itis means, inflammation wasn't part of the problem. So tendinopathy was kind of like a more accurate term. And the reason I think that matters to say is because a lot of the time people are like, oh, I have tendinitis. It's inflammation of my tendon. So I'll just get a cortisone injection and then my tendon won't be inflamed anymore. And I do think it's important then to like challenge the idea at its core. Well, if it's not inflamed, then the cortisone might feel helpful, but is it actually doing what you think it's doing, or is there something else going on? So tendinopathy means pathology of a tendon. And what does that actually mean? So it's a name that is given to tendons that have been persistently painful and they have a loss of function relating to loading. So what that means is just the tendon hurts, and it hurts when you load it, or basically that means when you use it. But for tendons, I don't like compression either. So it can be when you use the tendon, or when you stretch the tendon, or when you compress it, because all of those things are triggers. You don't need medical imaging to diagnose a tendinopathy because they have a very common set of symptoms. And as with imaging, so often the case, it's wrought with issues in that I'm going to use someone I know as an example. They had pain in a hamstring, so they got an MRI scan of their whole pelvis, and they actually had visible tendinopathy on both hamstring tendons. So they'd never had any pain on the hamstring tendons before, but their imaging showed tendinopathy to like the same extent on both, but they'd only had a short-term history of pain in one of them. So what value did that imaging show? It shows you a painless tendon that hurts and a painful tendon that hurts. Oh wait, hold on. It shows you a painless tendon that has tendinopathy and a painful tendon that has a tendinopathy. It just shows you how tendinopathy doesn't guarantee you symptoms. And something that's quite interesting is that on imaging, a tendinopathy doesn't look better when it's become pain-free. So I think the truth is that if you MRI anybody over a certain age, they'll have a tendinopathy somewhere, and you don't really know whether that tendon's going to start hurting or not. So basically, you don't need medical imaging to diagnose tendinopathy. You can diagnose it from location and symptoms, and someone who's trained to diagnose, which is physiotherapists, can do that with you. So just if you're wondering whether you have one yourself, they tend to follow a clear set of symptoms. So basically they hurt when they're loaded, or it might hurt a bit to start with and then warms up. Often as they get worse, that might not happen. They might just like hurt the whole time. They often feel worse upon waking the next morning. So it might be that like everything was fine at the time, but then the next day you notice it feels worse. And they often feel stiff or sore when you've been stationary for a period of time and then you move the affected area. So like a lot of people with Achilles tendon, they're like, oh my God, first thing when I wake up, I can barely put my foot down. And then, it gets a bit better as the day goes on. But if I've been sitting at my desk for a while and I go to get up, like it happens again. So that's like a classic tendon. It feels stiff, but it warms up. So as soon as you sort of have those symptoms, and it's a place where there is a big tendon, you might start to suspect tendinopathy. I have to say, tendinopathies in the upper limb, like shoulder and elbow, might present a little bit differently to lower limb, just because the upper limb is, you load it differently. Like you load your lower limbs all the time because you're walking, whereas your upper body, you don't load it anywhere near as much. So the pattern might not be so clear cut. So common places that get tendinopathy. So high hamstring tendon, and that's the top of my list because I've been suffering with that for like a solid 10 months. So it's like pain in your butt, basically, like pain where your leg attaches to your body. The Achilles tendon, so like behind your heel. The plantar fascia isn't a tendon, but often it gets tendinopathy and it gets a fasciopathy, like same kind of clinical process or injury process or pathology, whatever you want to call it. That's under the heel pain. Wrist extensors, so that's here, the outside of your elbow. So that's what people often call tennis elbow. It's actually your wrist muscles that cause that. And you could also get wrist flexors, which is the other side, which is like golfer's elbow. Patellar tendon, so that's the front of your knee. Less commonly quads tendon, which is like above the knee. Rotator cuff tendons in the shoulder, super common. And I'm not going to talk about them too much in this because it's like functions a bit differently to the other tendons. And gluteal tendons, which is the outside of the hip, which I've also kind of had a little bit of an experience with. Okay, so what is tendinopathy? Like, why does it happen? And as with everything in the human body, a lot of these things are somewhat theoretical because people don't know for sure. So the concept is that our tendons are designed to adapt to load, which means that if you load your tendon, like you run, for example, your tendons then adapt to that thing you did and get stronger, just in case you choose to do that thing again. Again, it's like the amazingness of the human body that it adapts to get conditioned to the things we put it through. So amazing. So if you use a tendon more than normal, so if you don't normally run and then you suddenly run, the theory is that your tendon should adapt to that load and then get stronger. When that doesn't happen though, if that process gets disrupted for some reason, instead of getting stronger, it becomes weaker and less able to handle load. And the reasons that might happen is you might load the tendon again too soon. So it might be that you run on Monday and then you run again on Tuesday and then again on Wednesday. And by the time you get to Thursday, something's sort of broken down in there and it's not repairing or recovering like it should. Or it could be that the amount of load itself was just way too much. Like you're someone that doesn't run and then all of a sudden you run 10Ks. So the tendon then, in order to like try and get stronger or try and adapt quickly because it didn't repair in the way it should, it can get like thick. So all these kind of other cells that are not tendon cells get put down into the tendon to make it thicker to try and go, okay, I'm bigger, I'm able to adapt to that load better. But that's actually not like a healthy tendon. So often you'll see someone who has a tendinopathy, the tendon's all like thick. And once that's happened, to my understanding, it's pretty hard to reverse, but you can treat the healthy parts of the tendon. So if you have a tendon with a little bit of a tear in it, or you have a tendon with these fatty deposits into it, or it's got degenerative portions in it, the idea is there's still going to be healthy parts of that tendon that you can improve. And when I say treat or improve, I don't mean with injections or surgery or anything. I mean with a targeted loading program for your tendon. So normally, and the way they figure this out is quite complicated in the research, so I'm just going to take it for granted that this is generally probably accurate. Tendons take about 48 to 72 hours to adapt to something new. Bear in mind that is an extremely kind of context person dependent response. So like someone who's a runner who runs 50 kilometers every week, who adds another 10Ks in, that person might adapt to that pretty well because it's not that much more than their tendons are used to already. So it's like that person might be able to get away with just adding a 10K run in between two other runs in their week with no real period of rest in between, and it's fine. Whereas if you're someone who never runs and you suddenly start running, you probably want to wait 48 to 72 hours before you try that activity again. And I'd say that's particularly true as you get older. And I'm going to say by older, I honestly mean over 30 now. But the older you get, the harder it's going to be to adapt to something new, but you definitely still can. And I guess it's also dependent on, it's like how much that load is, or how big it is, how different it is to what you're doing already when you're considering how much rest or recovery you want to take. And it also depends on your history. Like if you've had a tendinopathy before, it's something to be quite mindful of. So basically your tendons are the happiest doing stuff that they've been doing quite a lot in recent weeks. So whatever you've been doing for the past sort of 4 weeks or so, your tendons are likely to be pretty used to it. And so you can use that as a base to build from. I think people forget this a lot in that they think about what they used to be able to do. So bear in mind, within about 4 weeks, your soft tissues sort of have forgotten what you could do before. So your brain hasn't forgotten, and often, exercise has got a huge psychological component. You know how to push, you know what it feels like to do something hard. Often even like your strength and your ability hasn't gone away, but your conditioning to it might be less. And with tendons, they're particularly sensitive to like energy store and release stuff, which is like bouncing, jumping, running, those sort of things where you think like a spring has to go like big, small, big, small, big, small. So something I'd say that's like pretty common that I see is someone who's like an avid runner or who plays sport, who then has a month off, and then they jump straight back into like what they were doing before, and then they get a tendon problem, and they're like, what? I was like running 60 Ks a week 3 months ago, and I only just started running 12 Ks a week or something, and now I've got a tendon problem. That's weird, like it's nothing for me. But you have to consider that it's actually a lot for your tendon. And again, taking into consideration all those factors, age, past history, blah, blah, blah. Because there are people who are always going to be able to get away with this and escape scot-free, if that's the saying, and that's like cool for them. And I actually generally, I don't like being like, oh, you should do this to avoid injury, because you don't know if you're the person who's going to get injured or not. But I think once you have had an injury or you're trying to recover from it, that's when these things start to become more important, because it's like, all right, well, you've already had a tendon problem develop. So now we actually start to have to look at, okay, what's your loading profile look like? How well do you seem to adapt to introducing new things historically? Okay, like let's be careful about this now. I did sort of link something in the blog. Pete Maliaris, he's like an awesome tendon guy from Australia. He looked at how long it takes for a tendon to return to baseline after a period of detraining. It's considered to be about three weeks. So if you stop your activity, within 3 weeks, your tendon has sort of lost its capacity that it had before that. Not 100%, but it goes down a lot. And something that I think is really interesting to consider is like people who develop a pain, who stop activity, they're going to detrain. So it might be like, oh, this thing got really sore, so I've just been resting it for 3 weeks. Then they try to go back to what they were doing before, and the tendon pain comes on even sooner because they've deconditioned even more. And I do see that quite a lot as well. It's often with less active people that they develop a pain in their whatever, and they rest it, and they're on a background of already being relatively deconditioned. They rest, and then they get even more deconditioned, and then they can tolerate almost nothing, if that makes sense. So it is really interesting how quickly these things can decondition, and how much often rehab is actually about like building it back up in a manageable way. So even though I just said I don't really like doing like risk reduction stuff, because a lot of the time you can't stop things happening, I like to think of, in terms of reducing your risk of developing tendinopathy and injuries in general, the concept I like to use is the concept of capacity. So the concept of capacity is that, as I said, your tendons are happiest doing what they're familiar with doing recently. So in order to reduce your risk of developing a tendinopathy, you want to keep your overall capacity of your tendons high. So I'm going to use a specific example from my life to discuss this concept. So when I first started working full time, I all of a sudden was standing up all the time, and I wore these really flat shoes. And I'm a bit stretchy, so a bit hypermobile. So when I'm standing up, my feet over time probably just like flatten out a little bit. And no problem, that's fine, but it means that it stretches the plantar fascia under my foot. So when I started working full time, I got heel pain on both feet, which took like ages to resolve. But it got better. So it was like my capacity to handle standing for 35 hours a week in flat shoes wasn't there. Over a year, I built that capacity. So it's like, all right, I can now tolerate standing for 35 hours a week on flat shoes. A way to kind of speed that process up was to wear supportive shoes so that it wasn't as hard on the plantar fascia. And then over time, over years of standing all the time and also adding a fair bit of strength training, my capacity to handle standing for a prolonged period on any type of shoes got much better. So I remember my first few years working full time, I had to make this real point of getting really supportive footwear, which that need kind of like dissipated as my career went on. Then when I trained for a marathon, the heel pain came back. So it was like, at that time was teaching body attack 4 times a week, I think, was running 21 Ks totally fine. So if you look at my capacity envelope, it's like I can tolerate standing 35 hours a week. That's probably an exaggeration, but let's just say I can tolerate standing for 35 hours a week in relatively supportive footwear. I can tolerate running 21 Ks on a weekend and teaching 4 body attack classes a week. Running 30 Ks though, that was like outside of my capacity envelope, and I got heel pain. The second I stopped running after the marathon was over, it went away. And I haven't had that heel pain ever since, probably because I do way less running and jumping, and I swapped to doing heaps more strength training. I noticed that I can wear even like Nike Frees to do body attack now because I built that capacity so much for my feet. But the last 2 weekends, I went to a music festival and I danced in big heavy Doc Martens with no arch support, and over the course of a day I did like 40,000 steps one day, and I got heel pain 2 days later that lasted for like a day. And then I did the same thing the next weekend, 30,000 steps in Doc Martens, and got like pretty bad heel pain the next day, and then I proceeded to do 25,000 steps of walking in supportive shoes the next day, and now my heels, we're like on day 3, my heels are like really sore. And so it's that idea of capacity. So it's like, for me, my feet can handle 20,000 steps a day in pretty supportive footwear. They were pretty unhappy with 40,000 steps in Doc Martens, but it just pushed it enough to kind of make it sore, but then calm back down. But doing it again a week later, it was like, nah, that's enough. So that's a kind of long-winded way to explain what capacity is. But I think it's a really important concept to grasp, because patients will often go to me like, I want to fix my tendon. And it's like, yeah, you can fix it so that it doesn't hurt. But if you exceed your capacity, it'll probably always give you a bit of a warning pain again. So I don't consider myself as someone who has plantar fasciitis or plantar fasciopathy. I don't like have that. But if I exceed the capacity of my plantar fascias, they'll get sore. And I think that's probably true for like any of my tendons anywhere. But if I dramatically do more than they're used to, they're going to hurt. So that is a super long-winded way of saying, how do you reduce your risk? Well, you reduce your risk by making your capacity envelope as big as possible. So for lower limb stuff, honestly, it's going to be strength training and making sure you do include some energy store and release stuff, which is like some jumping stuff, and never not do that. Because that way, if you have to like run for the train or something like that, your tendons aren't like, oh, you haven't done any running in like 10 years. Your tendons are like, oh yeah, that's very similar to the movement we did like in the gym jumping. And I guess like you've got to apply that information specifically to your scenario. So what functional needs do you have? What do you want your body to be primed for? What do you want to be able to do that won't be like a total shock to the system? Okay, try to keep your capacity envelope big enough around that thing. But it's just like a general rule. Strength training through range and doing some jumping is going to keep you on track. So if you have been diagnosed with tendinopathy, how do you manage it? And I think this is like so important to cover, because most of the time people go off and get a cortisone injection, which is like pretty frustrating because it doesn't change the ability of the tendon to tolerate load. So like the way I see it is, tendinopathy is a failure of your tendon to handle what you asked it to do. So what's sticking a cortisone injection in there going to do? It's not going to suddenly make your tendon able to handle more loading. I understand if you're in just like excruciating, unbearable pain and you can't do anything, then an injection of some description might mean you can tolerate rehab, and that is like so your decision. And I have definitely had patients where I'm like, hey, go for it, because this is unbearable and I can't stand to see you in this much pain, and you probably can't either. But if I honestly think if you can by any means avoid the injection You should, and that's because cortisone in particular, it weakens your soft tissues. So if we know that tendinopathy never really heals, it just sort of gets better at being able to handle load, and that it is a problem relating to like a tendon not being strong enough. And then if we know that cortisone reduces the strength and integrity of a tendon, it's like, well, if I'm going to live for however many more years, I don't know if I want to be like reducing the capacity of my future tendon. Something to consider. So you might be like, right, okay, fine, I'm not going to get an injection, but like, what can I do? The first thing you have to do is offload the tendon enough for healing to occur. Again, this is going to depend on the person. So sometimes I will have patients who've come in 6 months into a tendinopathy and they've unloaded so much that it's the opposite. It's like, oh my God, you need to start doing some stuff on that place again. And a lot of the time, if they're like athletic, it might be that they've just been like pushing through, and it's just not getting anywhere. I am that person. They might need to be really coached to like reel it back in. And Greg Lehman, when I did his course this year, he had this really good point that it's like, if you've been dealing with something for a long time and you can't figure out whether you need to do more or do less, if you've already been doing one thing for a long time, you might want to try doing the other. And that, again, very simple advice is very accurate. So just looking at it globally, you need to offload it enough to recover. But if you've already done that for ages and it's still not good, you've probably done that enough and you need to strengthen it. And it is really important to only offload it enough to bring the symptoms back down to kind of just manageable. And then you need to do targeted exercises to strengthen the tendon in a way that won't aggravate it. So tendons are really sensitive to stretch and compression. So if you keep stretching and squashing a tendon and it's really sore, like it isn't going to get better very fast. And if you consider the fact that like part of the reason the problem developed is that the tendon wasn't strong enough to handle what you did and it's been progressively getting weaker and weaker, and then it hurts and you're offloading it more, it's going to get weak real fast. So you need to strengthen it up, but in a way that doesn't stretch or compress it too much. And as someone who's just experienced it really recently, it was really interesting to really experience the fact that it was like, well, it hurts all the time and everything hurts it, but things that made it noticeably very sore and increased amount of soreness for a full 24 hours after, and after some time that became very obvious what it was. That's the thing that had to go. So you do have to be very kind of, once it's been going on for ages and you really want it to get better, you probably do have to be quite conscious of like, okay, like what exactly are the things that noticeably make it significantly worse? I probably just need to do a bit less of those. And then as I say, you need to then directly load the tendon in a way that doesn't make it heaps more aggravated. And then you very slowly reintroduce the things that it would be like impossible to do at the start. Another thing that I think is very important to note is that if we know that tendinopathies don't like stretch or compression, sorry, there's a really loud thing outside. Podcasting in a gym problems. A lot of the time I think people only look at the exercise, and they're like, oh, I've got a tendinopathy, okay, I'm going to cut out this exercise. There is stuff you're doing all day at other times that will cause compression to a tendon. And I don't like posts on social media or YouTube or whatever that go, oh, you shouldn't do this because it compresses this soft tissue and that's bad for you. No, that's not true. If you don't have a problem, it's not bad. But if you have a tendinopathy and your tendon probably isn't going to like being stretched or compressed, and you probably do actually need to look at positions that might stretch or compress it and reduce them in order to get better. So, for example, when you have a hamstring tendon, just think of a hamstring stretch. Anything that stretches that hamstring is going to feel sore, and especially if it stretches it up at the hip. So it's something where like your leg's straight out and then you're also leaning over it. That's like peak, it stretches it and then it also compresses it against the bone while you're leaning forward. So for like hamstrings, it's deadlifting, sad face, but it's also sitting, and particularly sitting in hard chairs. And again, as someone who's just had this, I have to say like sitting in a hard chair was up there with like the absolute most painful thing I could do. Similar for gluteal tendinopathy. So it's stretched when your knee is up to 90 degrees or above at the hip, or when your knees across your body. So your glute tendon won't like those positions. It's also squashed to sleep on that side. So again, for me, gluteal tendinopathy, sleeping on that side, absolutely not. And like, it's not that hard That makes sense, right? Like if you're going to sleep for 8 hours on a tendon that is sensitive to compression, like that's quite a long time. Same with shoulder tendinopathy. They hate being lied on, and it's like, yeah, it's not bad for your shoulder to sleep on that side, but if you have a rotator cuff tendinopathy, don't sleep on that side for a while. I mean, you can, but it'll hurt. Then when you think of your tennis elbows and stuff like that, they're going to be compressed when, again, if you sleep on them or if your wrists are bent down for a long time. Plantar fascia or Achilles tendon, they're actually compressed if you're sitting in a chair and you've got your foot pulled back under you, like a calf stretch kind of position. If you're standing and leaning forward, it's going to be stretched. Actually high arch support in your shoes. And the other thing to consider is like massage, foam rolling a golf ball on a plantar fascia, stuff like that. Like they actually compress more. So a lot of the time those sort of historically suggested treatments like are not so great for your tendons. So they're kind of like the main things to consider. So it's like, all right, just consider things that annoy it and you need to just pull it back just enough to think for things to start to get better, and then you need to directly load the tendon. In order to directly load the tendon, you need to find exercises that don't really hurt it. So for example, like for a hamstring tendon, a hamstring bridge is a position where you're using your hamstring, but it's not stretching your hamstring, so it can handle that. And you progress to more degrees of stretch as your problem gets better. In order to actually change the tendon, the exercise actually has to be very heavy. Like it actually has to be really hard because you're trying to stimulate a response in the tendon to adapt and get stronger. So the exercises have to be hard. It's okay if there's some pain with tendon rehab because, to be honest, it's going to be pretty hard for there not to be when it's really sore. But again, like be very mindful of that 24-hour pain pattern. If it gets noticeably worse in 24 hours, it probably wasn't the right exercise. And then you need to gradually get back to activity. The big thing with tendons? Patience. Because the natural lifespan of a tendinopathy is like 6 to 12 months. And no matter what you read on the internet or whatever, you're probably not going to be able to cheat that time frame. So just bear in mind, like they can last for ages. And sometimes people go, oh, I can't be bothered doing like that strength rehab stuff. I'll just like get an injection because like I can't wait for it to get better. And it's like, you're still going to be waiting because like even if you get the injection or whatever else, and the truth is like it's actually still going to take 6 to 12 months to get better, and it might be like slightly less painful while you're doing it, and if you need that to get through, that's fine. But so often the research indicates that it's like better for a short period and then it just comes back. And the 1 year follow-ups, like often people are sort of, it's about the same. So to me, it's not like a quick fix to get an injection. It's like a sidestep almost. And I guess so often like, yeah, people get better in the long run and they'll be like, oh yeah, I got better because I had the injection. And it's like, often they'll get the injection and they'll allow like 3 months for the injection to fully take effect. And then they'll do like 3 to 6 months of rehab and then they're sort of heaps better and like, oh yeah, well I got better because of the injection. And it's like, no, you got better because it's been 6 months. That's not to say I'm anti-injection or anything like that. It's just like something to consider and something I see in practice over and over. The people seem to get better at about the same speed regardless of what intervention they've had. And I guess to me, the only thing that actually improves your tendon healing or loading capacity is going to be exercise. Obviously, all of that's anecdotal, but if you do look up the research, which I will admit in the past year, I have not read heaps of research since I finished my master's, but a lot of the tendon studies sort of show a similar thing whereby the first 6 weeks post an injection might have improved outcomes. They might be similar at 3 months, 6 months, 12 months. So it's like, if you need short-term pain relief to get you through, you go for it. But just know that in the end, the outcomes are probably really similar. There are lots of things I don't have that opinion about, but cortisone injections for tendons is absolutely one of the things that I'm like, avoid if you can. Okay, so just some quick little take-home points because I talked for longer than I meant to. So first, tendinopathy occurs when a tendon is loaded beyond its capacity and it gets less able to handle load instead of more able to handle load. Tendons like a similar amount of loading to what they've been exposed to in recent weeks. And when you consider recent weeks, consider the past sort of 3 to 4. So if you haven't been doing a certain activity for 3 to 4 weeks, that's long enough for your tendons to be deconditioned, and maybe just bear that in mind when you're choosing an exercise program to get back into. A sudden load, like a one-off huge amount of load, way more than your tendons are used to, or a repetitive load more than your tendons are used to, both can trigger a painful tendon. So treatment of a tendinopathy involves offloading the tendon just enough to allow some recovery of symptoms, but not so much that you're like doing nothing, and then specific strengthening for the tendon, and then a gradual reloading of activity. Offloading needs to consider both tensile and compressive loads, i.e. you need to consider things that stretch your tendon out for a long time or things that smush it, and you need to look at your whole sort of life, not just the exercise you're doing. So consider load on the tendon in static, prolonged postures like sitting, lying, standing, not just when you're moving or exercising. And once again, I honestly think those things are only worth considering when you've already got a pain that you're trying to get rid of. You don't need to think about them as like preventative things. Like there's no right or wrong way to stand or sit or sleep. A graduated return to activity is part of a rehab along with the activity modification and the strengthening, but you need to allow that tendons are very slow to adapt. It is important to avoid total rest, and obviously this whole process can be incredibly difficult to navigate on your own, and it can be like depressing because it goes for so long. So getting help from professionals, and honestly it could be physio or exercise physiologist, that's what you sort of need to get you through. So I feel like if you've been struggling for months and there's no progress, and especially if your life sort of started to shrink around it, you absolutely need to seek out some help. But hopefully the information I've given you in this podcast might mean that you're able to do a little bit more on your own before you need to seek help, because a more minor tendinopathy might just get better on its own with a few of those little tips. So thank you so much for listening or watching. The next one I'm going to do is how to deal with a prolonged period of pain or injury. Having just been going through it myself, I feel like I've got some really interesting insights just of things that might help kind of get you through, because obviously I see patients who've been in pain for ages, and now that I've been on this side for it, I can provide some insight. Any requests of anything you want to do, or if you want to go on a podcast episode with me, please reach out. Thank you so much. And thank you for listening or watching.